Hello everyone, welcome back to another episode of Research Works podcast. We're here once again at the pre-conference workshop at EACD in Melbourne, and I'm very thrilled to actually be speaking to this person in person this time around, because last time we spoke online, so it's always lovely to speak in person. Welcome, Dr. Sue Greaves.
Thank you.
So nice to have you.
Yes, lovely to be in this beautiful location, isn't it?
Isn't it amazing?
Yeah, and it's not raining.
I know, yeah. I've been looking at the forecast and yeah, it was looking, at one point it looked like it could have been too hot.
Yes, I listened to your podcast, which you said it was going to be cold.
That's
so
what
I
it looked
packed
like
all my coats.
We did as well. So anyway, we're prepared for all seasons here at this stage. Sue, last time we spoke about bimanual therapy. And when we think of your name, I think of bimanual therapy as well. But before we get into all of that, it would be really nice to know what it is that you're doing now for your work, what you do and how that influences things.
Yeah. So I've been an occupational therapist for many, many years and worked clinically for many, many years. But I was really privileged to work at the Children's Hospital in Melbourne, the Royal Children's Hospital in Melbourne, for 22 years, so a long time.
Yeah.
So, both in a clinical capacity, but then more latterly as the head of the department. So I guess I moved a bit more into management. So so a few years ago, I decided I'd had enough of and maybe maybe a change of focus again. So I'm really lucky to go back to some clinical practice.
Beautiful.
So with my very good colleague, Dr. Brian Hall, or Associate Professor Brian Hall, and we work in a lovely practice in Melbourne in Australia. So back to working with young babies and their families. So
you can tell you love it.
I love it. I love it.
Back at the roots.
Back at those roots. And and really, it's really great. I just really, I've always believed that a researcher needs to really be embedded in that clinical practice.
Right. Yeah.
So, so I've done lots and lots of, working over the many years in clinical practice. So it's lovely to be reverting back to it. But of course I do lots of teaching as well. So the assessments that we've developed as well. So
that's wonderful. And I love that, because going back to clinical practice, you always remember how it was when you were working in clinical practice. But it does do little tweaks and changes, policy changes. And so our interventions need to make sure they align. Yeah. Otherwise no one's using them.
Yeah, absolutely. And, it really brings back to what is current, making sure that you're current, hopefully you're current with what you're doing, but also really about what is the reality of clinical practice.
Yeah.
Research sometimes, you get in your own little cocoon and your own little kind of research world and
the controlled conditions.
Exactly, controlled conditions. You can go into that therapy or that therapy. And clinical practice isn't like that. So,
it's beautifully messy.
It is beautifully messy, but beautifully, what are your clinical decisions and your clinical reasoning for using interventions or, when you should be doing things. So I think it's always great to go back to it. So yes, I'm very much enjoying working with babies again.
Really great. And when we think about bimanual therapy, why do we always think about you?
Well, it's really interesting because, why bimanual therapy? And I've always worked, I've mostly worked with kids, and then kids with cerebral palsy, and then more and more with kids with unilateral cerebral palsy. So that's absolutely my passion. And I think that the big, and I've done lots and lots of training, as I said, because I've done work for many years, but the big aha moment was way back in 2004, so a long time ago, when these two fantastic Swedish therapists came over, Linda Krumlinda Sundholm and Ann-Christina Lysen, and they taught this assessment called the aha. And
I know, I always do that.
Well, there was this huge aha moment for me. And I actually was enrolled in my master's at the time. And my master's was in looking at botulinum toxin injections in the upper limb with young children. So kids, 18 months to 4 years in the upper limb. And when I was doing it, I was really trying to think of what was a good assessment that I could be using for kids for this trial to prove intervention. And, way back then, there wasn't these assessments around. So I had to use the Peabody, which is a developmental assessment and which really doesn't measure what we're interested in. So it's it doesn't, it's a test for kids with typical development. So why is it going to be measuring what we're interested in with kids with, movement disorders? And, I used the CAPM and gas, of course, and that was fine. But it was really like, what upper limb measurement does measure the important things for these kids with unilateral cerebral palsy.
Yeah.
When do they
pick up the changes? Yeah.
That's right. When they use it. So doing that AHA assessment, 20 whatever years ago it was like this huge moment for me. But I do absolutely remember walking in the park with them and saying, you're starting at 18 months. Can't we develop this younger? So, because younger babies, use two hands, and we need to be encouraging two hands in younger babies. So, that's why I did my PhD in developing the AHA down to this younger age, which is the mini AHA between 8 months and 18 months. But, the concept of the AHA is such a beautiful concept. And so the concept of the AHA is that when do children with unilateral CP typically use their affected hand? Brilliant. And they typically use their affected hand when they need to or they have to. So that's during bimanual task performance.
Okay.
They do not use it for unilateral tasks, just like I don't use my dominant hand for unilateral tasks. I don't brush my hair with my left hand or clean my teeth with my left hand or write with my left hand. I use my left hand, which is my non-dominant hand, primarily in bimanual tasks. So I use it all the time because actually I think they did a study which shows you about 80 to 90% of tasks are using your two hands, together, during your everyday life. But I use it when I need to or have to use it, because whereas unimanual tasks, I use my dominant hand. So when you think of kids with unilateral cerebral palsy, what do we need to train? What do we need to train?
Yeah.
We need to develop skill, of course, in our in that affected hand. But what are we developing skill for? We're developing skill for better performance in bimanual tasks.
That's beautiful.
And, and so what does that look like? We know, again, that bimanual tasks are more complicated than unimanual tasks. It involves the, coordinated use of two hands. It involves temporal and spatial coordination. So it is more complex and it's more difficult, but that's what we need to train, because we know in terms of thinking of motor learning theory, you need to be specific and you need to train what you need to use. You know what I mean? So
that's wonderful.
Bimanual. Yeah.
In case we missed it.
Bimanual is really important. And, specifically for these kids with unilateral cerebral palsy, but also for bilateral kids, who don't have good coordinated use of both hands, because we know we get better if we train what we need to learn. So, yeah.
And it sounds like from there, you're passionate about it, and I love that, because when we often, I guess the contrast here is often that for unilateral, the focus has always been on unilateral skills. Which is such a, when you just explain it that way, it doesn't make any sense, does it? When in terms of, it does make sense, but it doesn't make any sense at the same time, because you want to train what you need, but yet we're withholding it for so long, and then suddenly they need to use it.
That's
the problem, isn't it?
Yeah, and I think that, constraint is... absolutely. Do I use constraint?
Yes.
Absolutely, I use constraint. It is really important to build skills, for sure. But you need to know, what are you building skills for? So you're building skills to make that affected hand a useful assisting hand or, helping hand.
Yes.
You're not building skills for that to make that a the dominant hand.
Make it the dominant, which is phenomenal, because we wouldn't expect that for ourselves, for us to use our non-dominant hand, but yet I've seen goals written for basically the non-dominant to become the dominant.
Exactly, like that they can be better at spoons. I don't use my my left hand for feeding myself with a spoon, so why would we expect a kid with unilateral CP to do that? So I really think that, I absolutely acknowledge that bimanual training is more complex than maybe unimanual training. And so really, because what drives bimanual performance? So bimanual training, I will quote. So what is bimanual training? So, we define it as the bimanual therapy is a process of learning bimanual hand skills through repetitive use of carefully chosen, goal-rated, two-handed activities that provoke bimanual actions and behaviours. So basically what we're saying is that here's a task that you need to use two hands. So it's all about the task the activity that provokes bimanual performance, and that can be really difficult in very young babies,
yes,
and very young children. So what provokes them to use two hands? And I think that can be difficult for clinicians. One, they have to know what age-appropriate tasks are, but they have to specifically know what are appropriate bimanual tasks. And what's the tricky thing here is that kids at different levels of ability have different bimanual tasks that you need to be provoking.
For sure.
So, kids with low ability, how do they use their affected hand during bimanual tasks, as compared to kids with moderate ability as compared to kids with high ability.
For sure.
So not only do you need to know age-appropriate bimanual tasks, but you need to know the strategies that kids with different levels of ability they use, and really, write very specific action-focused goals around those, different levels of ability, and what you're trying to encourage.
Yeah. And that's speaking to, task specificity almost sounds too simple of a term there, but that's exactly what this all is, isn't it?
Exactly.
It's age dependent, it's skill dependent, the function that is required.
Yeah.
And when it comes to developing that intervention plan, I imagine that's where the skill of a therapist really comes into place. Because I think sometimes there is almost that mourning and sadness of when we say, let's not touch the kids so much. To try to get, that doesn't mean we're completely hands off, but it does mean that we might be guiding, and there is almost that sense of, oh, what am I there for? But in fact, it is huge.
Huge skill in the therapist. Doesn't need to be hands-on. Absolutely. In fact, it shouldn't be hands-on.
You're problem solving as much as they are.
Yeah, exactly. So it is like, what is the appropriate toy, for this child's skill and ability level? But, how do I provoke, how do I present the toy? If they're not doing what I want, how do I, what strategies am I going to use to encourage, the skill that we want to use?
Sure.
What are the strategies that they need to learn?
Yeah.
I'll give you an example. So, say kids with moderate level ability, we know that they have lots of difficulty picking up from the table with their affected hand.
Yeah.
So a better strategy for them is actually to pick up with their preferred hand and to transfer into their affected hand.
Okay, great.
So what's the strategy that we're going to use to teach that strategy?
Yeah.
Because the other thing about bimanual therapy is that it's very much more a cognitive perceptual skill. It's not just about motor performance, whereas constraint is maybe, or, unimanual development is more maybe about, just training a skill.
Very repetitive in this
That's
way.
right.
This orientation.
That's right. This is what
and
this is that. I'm not saying that skill development is really not really important. It is really important. But, with bimanual therapy, they have to figure out that they have to use two hands for one. But they have to figure out, how is the best way I'm going to use these two hands for this particular task. And that's going to be different for kids with different levels of ability. One of the big tricks the big difficulties we have is, when can they recognize that they need to use two hands, and what age? I'm working with very young babies, so babies under 2. So when can they recognize that two hands need to be used?
Of course.
And depending on their ability, what strategies do we need to teach for those different levels of ability? Because I don't know if I'm sure you do know that in the REACH trial, we found that there was this, category of kids who didn't improve. And these were the low-level kids, that moderate level, and the high ability kids improved beautifully, but the low-level kids didn't change. And that didn't matter whether it was bimanual or whether it was constraint. So it was both, interventions didn't improve them.
Interesting. And what do you think that means for us as clinicians moving forward, if they are these base goals? Because there often are base goals for upper limb, and what strategies or solutions do we have at the moment?
None. Well, that's right. So I think that's a really good question that we really need to be thinking about. About why aren't these kids improving? And I think there's a number of factors, about it. And I think there's a number of people who are trying to address those factors. So there's people who are trying to address it through a sensory perspective. And so I think there's a presentation on Thursday from a Dutch group, looking at sensory input into.
It's looking very interesting.
Yes, that's right. I can't remember what it's the acronyms,
but I do forget the acronyms from time to time.
So they will present. I'm sure they will learn.
We'll look for links for that. Yes.
Yeah, so which is really interesting, I think. But I do actually think that, you know, what I've been saying is that bimanual hand use is a cognitive has a cognitive component as well. So I think that is really important.
Yeah.
And then I also think what's really important is that understanding how kids who are older use that severely affected hand as well.
Yeah.
So we know through the AHA and all the work that has been done in AHA and intervention that that these older kids, the two strategies that they use is something called stabilizers by way of support. So they kind of put their fist on a toy to stabilize it, or an activity to stabilize it, or sometimes they might, you know, push toys into that hand. So that's a really cognitive, you know, that
if
as
a solution strategy.
It is a really solution strategy. So when can young kids learn that as a strategy?
Sure.
Or, you know, maybe what are the skills that we can build up? Can we build up those skills at an earlier age so that, you know, as soon as they're able, they can use it as a strategy?
That's such a good point, because it does come down to the moment the child realizes why I need to use it.
That's right.
And that is the core component of it.
It is
it?
The core component of it.
What is the function here that's going to drive me to be motivated enough to want to look for a solution in the first place? And
absolutely.
And what's the demand we're placing on?
Yeah, absolutely. So I think that is a really. I think that you really need to remember that when you're treating very low kids, they are never going to use that hand as their preferred. They're never going to use it for unimanual performance. They are only going to use it for when they have to.
When they have to. And so, what is that situation that we would?
What is that situation?
Good point.
Exactly.
Yeah.
So what's the situation, and what should that hand function look like? So I think that's going to be the next really big phases of, you know, how early can we teach it?
That's exciting.
How early can we think about developing those skills? So
very thought-provoking. So Sue, I mean, again, you always teach me so much every time I speak with you, and always compel more thought. From your perspective, if you had one main message for therapists that you really want them to grab and take away with them from our conversation today, what would that be?
I think that there's still a lot of constraint being done in the world. So I think that there's still a lot of you know, countries that are introducing, or not introducing, but implementing constraint programs. You know, I see across the world, particularly maybe in America and North America. So, you know, I think that
think bimanual.
Think bimanual. If you want to take away a message, of course, from me, it's going to be think bimanual.
Well, so I think after today's conversation, the way you set it up and the process behind it, why wouldn't you?
Why wouldn't you?
So I think that was a beautiful thesis right there and then. Yeah. Well, thank you so much for sharing with us today, for sharing at the conference. It's lovely to speak with you, and I can't wait to see what comes next. I can already tell what's probably going to be coming next. To all of our listeners, I hope you really enjoyed that as well. That was just amazing. We'll put links, of course, to everything that's been happening at the conference, but stay tuned and we'll talk to you all again really soon. Goodbye.
Bye.